What we do to close a fistula is we bring up a segment of intestine and sew it to that opening. It's not satisfactory just to stitch the fistula opening closed itself, because that breaks down. That's not a highly successful procedure, whereas this is. Some people have mucus that is very thick and jelly-like, and if you have a BCIR or a coke pouch, that's very convenient, because you're not going to get very wet in between intubations. You have it confined with a nice dressing, maybe an Ampatch dressing designed for continent diversion pouches. Some people have mucus that's very thin and watery, and they feel like water just pouring out of them. That's much more common in the early weeks or months after surgery, when people are catheterizing more frequently. And as time goes by, the way the pouch is designed, mucus flows back into the pouch rather than out of the stoma. So that's just a management issue that's not difficult to overcome or deal with. And here's an example of many different kinds of patches. And some of them are, as I mentioned, the Ampatch product is very much specifically designed for the continent stoma. J-pouch statistics. Yes?
There's no dietary restriction.
Okay, that's a very good question too. Most of our patients say they eat anything they want. Some things take longer to break down and digest. So if you eat a Chinese chicken salad with water chestnuts and bamboo shoots and all that stuff, it may clog the catheter. So you feel full, you sit in the bathroom, you put your tube in, you get a little flow, but you're not finished draining and you're still full. You take the catheter out and a piece of mushroom is still clogging the hole. You have to take it out, put the tube back in, drain. So some people will avoid certain foods because it takes too long in the bathroom. I mean, most people catheterizing, it's a few minutes. It's not a half an hour to empty your pouch. But if you eat a pizza with everything on it, those types of foods, it may take longer to empty later on. But remember that the food that you eat is sitting inside normal intestine. Unlike a conventional ileostomy where it comes out of the stoma and it goes into the appliance. There's no more digesting going on there. Here in the internal pouch, it continues to digest. So what doesn't come out initially will keep breaking down and is digesting. Body's absorbing nutrients during that time, and then it comes out at the next intubation. But most people eat anything they want.
Some of my patients have had ileostomies for a long time. Their stool thickens up, so it's a soft paste. Does this happen with the internal pouch?
That can be a management issue as well. Some people do have very thick output, and if it's like toothpaste, it's not going to flow through that catheter. So the solutions are flush water in through your catheter to add water into the material. It thins it out. It'll flow out easier. And some people flush every time they intubate, they catheterize. Some people don't want to be bothered. And so they regulate the thickness, the consistency of their output with dietary measures. The most effective thing that's been found is grape juice in small amounts. We're talking about 4 to 6 ounces, not 2 quarts of grape juice a day. That causes most people to have a stomach ache. But small amounts of grape juice, sometimes several times a day, sometimes once a day. Drinking a little extra fluid. We have lists of foods that thicken the output if it's too thick, and foods that cause it to get thinner, the same. For people who have this kind of toothpaste, kind of small bowel effluent, some people benefit from being on lactulose. And lactulose is by prescription, but it's not really a medication, but it's used for chronic constipation. People who have their colon and chronic constipation. But with continent ileostomy patients, we give it in very low doses. So we're talking about a teaspoon once or twice a day, and that will reliably thin it to a good consistency so it's easy to evacuate. Most people manage that with dietary methods. So before I comment on this, and we have only a couple more slides, and then we have plenty of time for questions. Rook ileostomy, the reoperation rate, if you have had a proctocolectomy and a conventional Brook ileostomy, you have a 1 in 10 chance of needing another operation during the rest of your life. Because stomas can develop hernias, parastomal hernias, stomas can retract, stomas can prolapse, show pictures, fistula can develop neurostoma, and sometimes the operation, the revision, is kind of a minor surgery, and sometimes it's a more major surgery, going back internally and relocating the stoma, moving it from the right to the left to find a new site for it. J pouches, and this this is from many articles. It's a kind of a summation of many articles. If you have your J pouch with a surgeon who does 50 or 100 or more in a year, you're going to be way at the very low end of this failure rate scale. And if you see it, if you go to a surgeon who does 1 or 2 a year, you may be in the higher end of the reoperation rate. Some people included in reoperation rate for J pouches are people who need dilatation. Sometimes where the pouch is connected to the anal canal gets tight. Too much scar tissue develops and it's hard to evacuate. Well, that needs to be stretched. Sometimes that's done under anesthesia. We call it a reoperation, but it's hardly a reoperation. So we differentiate major and minor. Major operations are people who have a fistula, have to have their pouch taken down. Sometimes a J-pouch surgeon will have a patient where the J-pouch hasn't functioned for an external reason, that kind of suture line, and they'll take it out and make a new J-pouch. It doesn't mean you can't have another J-pouch. That wasn't done 20 years ago, but in recent years it's becoming more of an option. It's still a very individual decision because anytime we take out a pouch, we lose about 1.5 to 2 feet of small intestine. And we can't replace small intestine. So if we make another pouch, J-pouch or BCIR or Coke pouch, we have to appreciate the potential that that pouch will one day need to be removed and that pouch patient now they're going to lose another 2 feet of intestine. So when it comes to making a second pouch, we're very careful about it. We measure the intestine, either by GI series initially, but then at surgery, we unravel all the intestine from the stomach down and use a long, 2.5 foot long suture and lay it out and keep adding it to itself and see how much intestine you have. If there's not enough, making a second pouch can be dangerous because we definitely want to avoid the short bowel syndrome, where you don't have enough intestine to properly absorb nutrients and maintain a good, healthy life by eating normally without intravenous nutrition. Risk of continuing colitis and risk of cancer. There are many surgeons who do J pouches and they leave a little bit of the lower rectum because it improves the results. There's less stool frequency and there's less incontinence. But that leaves a little bit of that rectal mucosa or transitional zone, which can cause what's sometimes called cuffitis, what other people call residual ulcerative colitis, in those little islands of lining. And there's a risk of cancer if that tissue has been left there. So if a surgeon has not removed the entire lining of the rectum, then they will recommend to you that every year you have a scope. And it's obviously a lot easier to do than a colonoscopy. It's just done in the office. But they want to make sure that everything continues to look healthy. Coke pouches have been studied. Let's go back here. The J pouch is, we're talking about 20 years, because that didn't become popular until the early 80s. There's longer experience with the Coke pouch from Europe and from the United States. So we have 30 years. When you look at failure rate, we have to turn it around. So if we look at this the other way, you say that, well, say 70 to 80% of people will have a good functioning, good to excellent, 97% of those people for 30 years. Now, 20% failure is high. That's 1 in 5 people. But this represents statistics, like we said, for 30 years. We're back to the 70s and 80s. And nowadays, many people who used to have their Coke pouch removed because of a problem have it repaired, because our techniques of repairing pouches have improved. And some patients will have a Coke pouch removed and have another one created. So if you get 30 years from one pouch and you're a candidate to have another, now you may go 60 years, and that's pretty much your lifetime if you're starting at 20 or 30 or 40 years old. You can't really expect to get to 101, although some of us will. So the reoperation rate also varies a lot because many surgeons did Coke pouches. They did 5 or 6 a year because it wasn't that common in their individual practice. Those of us who do pouches on a regular basis, where maybe we're doing several in a month, every month, and doing revisions as well as new pouches, reoperation rate is lower. Remember, I said with a conventional brochiliostomy, the reoperation rate is, I said 1 in 10, it's actually 11%. And so here with a continent diversion, which is a much more complicated operation, it's more in the range of 20%. The 57%, I mean, I listed it in the statistics in the literature, but those are old numbers. So our findings are